tiny challenges and childhood cancers. How does childhood cancer differ from adult cancers?
In adults, we come across breast, lung, stomach, uterus, cervical cancer. In children, we get leukemias, blood cancer, lymphoma, brain tumors, bone tumors, some of the abdominal tumors.
Okay.
Fortunately, the good news is majority of the time childhood cancer is curable.
Adult cancers over the age, a lot of pollution exposure, a lot of carcinogen exposure, and eventually damage. Would you attribute the same factors to childhood cancer as well?
95% of childhood cancer, we do not know what is the exact cause.
Can childhood cancers be linked to some influences when the mother is, having pregnancy?
Most of them will be adolescents.
Correct.
The first thing is, other than the cure and the limb salvage, we are focusing on fertility.
Welcome to Oncoflix podcast. Today we have with us Dr. Intezar Mehdi, Director, Pediatric Oncology and Hematology at HCG Hospitals. Tiny challenges and childhood cancers. We will explore how the tiny tots get over the challenge of cancer. Thanks, Dr. Intezar, for coming on our podcast. It's been a pleasure.
Thank you,
Welcome,
Dr.
sir.
Lohit.
Yeah.
Thank you, Dr. Krishna.
So, how does childhood cancer differ from adult cancers?
So first thing is, fortunately, childhood cancer is not very common. It's uncommon. So overall, if you see, approximately 1 in 10,000 children will develop cancer. And if you talk about the types of cancer, majority of the times in adults, we come across breast, lung, stomach, uterus, cervical cancer. In children, we get leukemias, blood cancer, lymphoma, brain tumors, bone tumors, some of the abdominal tumors. So the type of cancers itself is different in children. Second thing is the disease biology is different, and majority of the time children do not have comorbidities, and the treatment approaches are far more aggressive.
Okay.
Fortunately, the good news is majority of the time childhood cancer is curable. So that's the difference.
That's the good news.
So, sir, when we talk of pediatric cancers or childhood cancers, adult cancers, we know it has been on a race. If you have to plot a graph, are the childhood cancers also on a race, although it is rare? And the second point is adult cancers over the age, a lot of pollution exposure, a lot of carcinogen exposure, and eventually damage. Would you attribute the same factors to childhood cancer as well?
That's a great question, first of all. If you see like you said, if you plot the incidence of childhood cancer in the recent times, we definitely see that the graph is moving up. But
It is going
really,
up.
yeah, it is going up. But if you really look deeper into it and take a deep dive, then actually the incidence of childhood cancer may or may not have been increased. But the thing is, we are diagnosing it more.
Mhm.
The
Right.
awareness is more, and probably we are reporting it better.
Right.
Mhm.
That may be the reason we are
Correct.
seeing increased numbers.
Mhm.
And secondly, you talked about environmental influences and lifestyle influences, for example. So, environmental influences, like, for example, or pollutants or lifestyle, for example, smoking and other, ill habits, they have such a strong association in adult cancer. Same is not true for childhood cancer. The reason is because these pollutants and these carcinogens have a time lag. They
Right.
require so much of time to cause cancer.
Exposure.
Exposure, it happens over a period of time. But having said that, there are many other things that we actually don't know, and it's a learning curve. And maybe over a period of time, we'll be able to detect more and more reasons why cancer happens in children. But at this point of time, 95% of childhood cancer, we do not know what is the exact cause.
Mhm.
Right.
Only in about 5% of the childhood cancer, we know that either genetic influence or some kind of environmental influence or rarely some infections, for example, are associated.
So, can childhood cancers be linked to some influences when the mother is, having pregnancy? So, is it like some kind of exposures in, the pregnancy which can cause childhood cancer? Like, for example, smoking. Okay, if a mother smokes during pregnancy, could that also be linked to cancer?
Right now, I can say that it is work in progress. We do not have a dogmatic evidence to say that these are the things in pregnancy which are directly linked to causation of cancer. But having said that, for example, infections during pregnancy, we all know torch infections, for example, other infections, or for example, smoking and other illness that the mother gets during pregnancy is linked to so many other things in the fetal well-being. For
Mhm.
example, growth, development, brain development, and so on and so forth. But at this point of time, exactly exposure to this kind of things or this kind of infections or ill health during pregnancy is not directly linked to some childhood cancer, but it's work in progress. What is true
Correct.
today may not be true tomorrow. We might
Exactly.
come across new findings. Yeah.
So we always call cancer as a tug of war. On one end, there is damage, and on the other end, there is repair. So when we talk of repair, the genes that are responsible for repair plays a huge role. And does this hold true in childhood cancers as well? The repair genes and the deficiencies, how commonly are they associated with this?
Well, there have been some childhood cancer. For example, let us take the example of the eye cancer. For example,
Blastoma.
retinoblastoma. For long, that has been associated with the retinoblastoma gene,
Mhm.
and especially the familial type of retinoblastoma, where children may get bilateral retinoblastomas. Similarly, in osteosarcoma, for example, we have a strong association with the TP53 and few other genes. We have few genetic association now in leukemias as well. So there are some specific cancers where we have been able to detect either there are tumor promoter genes or tumor suppressor genes, one of the two which are playing a role. But rest of the things, again, it's a learning curve over a period of time. I think more and more genetic basis of cancer will come. And maybe in a decade or two, we will be, diagnosing children cancer and managing so much differently actually based on the genetic basis.
So we know that there have been a lot of precision medicine initiatives with respect to adult cancers, and now we have also got that into pediatric and childhood cancers as well. Is that the reason why different tumors respond differently to certain treatments?
Yeah, absolutely. Like, for example, let us take the example of leukemia, which is the commonest cancer in
Mhm.
children, what we commonly call as blood cancer. Children who are below 1 year of age, they are called as infantile leukemia. And we
Okay.
all know that traditionally the cure rate of this group of children has been very poor. If children are between the age of 1 to 10 years, their cure rates are in the range of 80 to 90%.
Mm.
Whereas if children are below 1 year, in the last 20 years, the cure rate has improved from, we can say, about 30% to 60%, which is
Oh,
still dismal.
okay.
But now, for example, let us take the example of blinatumomab, which is a new immunotherapy agent which has come for treatment of children with leukemia. And this monoclonal antibody or immunotherapy has revolutionized the cure rate in this group of children from about 50-60% to close to 80 to 90%. That's a
Okay.
huge change. Similarly, brain tumors, which you and I we manage together many times, we come across discussion. Let us say medulloblastoma. Take
Correct.
the example of the brain tumor which comes in the posterior part. We used to manage based on the location, histopathology, surgery, radiation, and chemotherapy. But now things have changed. We go to the molecular
Molecular.
level,
Correct.
Yes.
we classify at the molecular level, and then we are able to categorize them into low risk, intermediate
Intermediate
risk,
risk
and high risk.
markets.
And the treatment is tailor made according to that. So that's the role of precision medicine, which is coming in a big way and it's changing the paradigm,
How
the
we
way
treat
we treat.
cancers as well.
Yeah.
Sir, oncology is an ever evolving field. So you are a pediatric oncologist, but you also are very much aware of the advances that has happened in adult malignancies. If we have to compare the evolution that has happened with respect to drug discovery or newer treatments or better outcomes compared to adult cancers from 1980s till now, would you say pediatric cancer management has been on par with newer discoveries compared to adult malignancies, or as a pediatric oncologist you feel there is more scope for more discoveries?
If I tell this, it might be controversial. Majority of the time, the childhood cancer rates have been very good. If you see the Western data, actually, they have reached close to 80%. And in
The control
uh, the cure rates
cure
in
rates.
childhood cancer overall. But there are some cancers like leukemia,
Hmm.
Hodgkin's lymphoma, or Wilms tumor, where the cure rates are excellent, close to
Hmm.
90 and above.
Hmm.
But there are some cancers, let us say, for example, brainstem glioma, for example, or let
Mm.
us say metastatic neuroblastoma,
Hmm.
metastatic osteosarcoma, where
Hmm.
the cure rates are dismal. We are able to cure only less than 30 to 40% of the children.
Hmm.
So there is a huge gap. So a lot of efforts have been made to, try to change the approach by chemotherapeutic agents, different, combinations, so on and so forth, but that has not helped. But in the recent times, the molecular level, the genetic level, when we are able to, diagnose these tumors and we are able to tailor make the treatment based on targeted therapy or
Hmm.
immunotherapy, then that's making a huge difference. Here, I would like to quote one example. Like, for example, metastatic neuroblastoma, where there is bone marrow involvement, extensive disease. We used to do chemotherapy, surgery, bone marrow transplant, radiation, and maintenance therapy.
Hmm.
In spite of that, we were able to cure only 30 to 40% of children. But now we have a monoclonal antibody immunotherapy, anti-GD2, which we call it as
Correct.
dinutuximab. With that, the cure rate has changed from 40% to 70%. So that's a huge
That's a huge
change.
jump.
So yeah, that's a
Mm.
huge jump. So, but we always start quoting Western data, but what is our data, for example? There is a huge gap. For example, in the centers like we practice in HCG and the other good oncology centers in the country, the cure rates might be on par with the Western data, like similar to the adult data. But for example, there might be, rural areas or where there is no access for treatment, or there is unpublished data where the cure rate is lagging far, far behind. About 15 years ago, when I started practicing pediatric oncology, at that time they reported, data in childhood cancer was in the range of about 30%. Now we are catching up and we are coming to somewhere around 70 to 80% similar to the Western, but that is only in the some centers only.
So to summarize, can we say that since majority of pediatric cancers do well with the standard treatment, there really hasn't been a need for evolution there, whereas there has been some subtypes where there is resistance to the standard treatment, and that is where evolution is happening.
Yeah, actually, yeah, you are right, actually.
So, in the era of precision medicine, you told about, you know, focusing on the Western data. Do you think the same genomics will apply, in childhood cancers where there's a lot of Western data which is available? Do you think the same kind of concepts are applicable to the Indian data, Indian patients as well? Because probably our genomics could be different.
Yeah, yeah, absolutely. I think our genomics are entirely different. We all know that the Caucasian data and the data from the Negro population or the data from the Mediterranean will not be the same as the Asian population. We all have worked in different setups, including in India as well as abroad, and we come across patients from different descents. So the genomics is not going to be the same. So there is no blanket protocol that this protocol can be directly applied to our children when we are treating.
Customization.
Yeah, it has to be tailor made for the situation. That's where the role of precision medicine comes. Because sometimes, some children do respond to treatment and some children do not respond to the same treatment, same disease, same age, similar kind of body weight, but still. And sometimes, some children fall apart, means they have a lot of toxicity because of
Correct.
chemotherapy, and some children tolerate it pretty well. So these are all, maybe it's at the genetic level. So nowadays, majority of the time, at least in the centers where we are practicing, we definitely apply the data according to us. We just don't, follow the Western protocols for our children because it has to be customized based on the requirement that we have.
Like, for example, recently we had a germ cell tumor where
Yeah,
we had to completely change the protocol
yeah,
because it's one of the curable
yeah,
cancers.
yeah, yeah.
And, now the patient is doing well,
He is doing extremely well. Yeah.
from the condition where he was to
Yeah,
now.
yeah,
I think it's been a great, great
yeah,
improvement.
yeah, yeah.
So, talking about this high dose chemotherapy and bone marrow transplant stem cells, it is used more widely in pediatric cancers than in adult cancers. Talking from a outcome perspective and toxicity perspective, how would you grade it, and would you want a replacement therapy to this?
We will not have job there. So yeah, on a lighter note, but on a serious note, yes, you're right. See, if you dissect the bone marrow transplant a little bit deeper, then you have two types of transplant. One is autologous, where you use patient's own stem cells for transplant. That's the simpler ones. And this is useful in oncology, majority of the time in pediatric solid tumors and in lymphomas, for example, Hodgkin's, non-Hodgkin's that relapse, neuroblastomas, for example, or brain tumors. But the real transplant is allogenic, where we use the stem cells from a donor. The donor, majority of the time, has to be a family donor. It has to be HLA identical, sibling, or parents, half match, or from unrelated donor from the registry. This is the real transplant because here you first, give high dose chemotherapy to the child because you have to create space in the marrow, and then you infuse the stem cells which you have taken from the donor. Here, the main problem is infection, majority of the times, because they are immune suppressed at that point of time. Their counts are going to be flat. So they get lots of infections, bacterial, gram-negative sepsis, fungal infections, viral. So this is the key. But if you carefully plan the bone marrow transplant, you can to large extent limit the toxicity. And you can actually mitigate the risk of transplant by various strategies, not only having HEPA filtered rooms, well trained staff. So, this has to be done in centers who are well accomplished. They have taken their, proper training of the staff, and it's a multidisciplinary team approach majority of the time. And you can give prophylaxis, like, for example, to limit the bacterial infection, prophylaxis to limit fungal as well as the viral infections. So careful planning is very important. Bone marrow transplant is never an emergency. It's an elective procedure. So peri-transplant planning is very, very important to limit the toxicity as well as other complications. And then you do benign hematology transplants, for example, thalassemia, aplastic anemia, which are not cancers as such, but that's potentially the only curative option we have. And especially the challenge there is without transplant, for example, thalassemia child is not going to die. He's going to still live with, transfusion and chelation and other things, but they're not going to have long, normal lifespan. There's a lot of morbidity. So when you do transplant, for sure you have to be successful. There is no room for error there. Okay, so your cure rates have to be excellent. So benign hematology, majority of the time, our cure rates have to be 90% and above. Whereas when we are talking about oncology, let us say leukemia, if we are doing allogenic transplant at relapse, maybe our cure rates are in the range of 50 to 60%. But without transplant, it's zero. So, I mean, that's where we are. Having said that, if you say what is the ideal thing which can replace bone marrow transplant and whether it will be less toxic, nowadays we hear a lot about CAR T cell therapy, for example. So nowadays there are preliminary data in children, especially in B cell leukemia and lymphoma, where CAR T cell therapy has been found to be useful in relapse refractory cases at the second line. But soon it is going to come as the first line, and probably, those children who are not that fit or who have received heavy chemotherapy or probably who didn't respond to chemotherapy might use CAR T cell therapy as a bridge therapy or a definitive therapy.
So in adult cancers, immunotherapy is come to the prominence. It's like an organic way of treating cancer where you try to potentiate your body's immune system to detect cancer cells. With respect to childhood cancers, are you incorporating immunotherapy more into your clinical practice, and has it created that kind of an impact as it's created in adult cancers?
Now, see, in pediatric hematology and oncology, we are kind of, a little bit of conservative people because we will have to get the data from the adult setup, clinical trials, phase one, two, three, and then there has to be enough long-term data to say not only it is efficacious, but it's not going to have a lot of toxicities immediate and especially long-term. Because here you are curing the child forever. You're not talking about 5-year disease-free
Right.
survival.
Correct, correct.
A 10-year-old child has to be normal when he's 40 or 50. They have to have a normal career, life, family, children, so on and so forth. So that's why we wait for the long-term data. But having said that, like I mentioned, in leukemia, for example, in ALL, we use now immunotherapy, glinatumomab, for example, for BCL ALL, anituzumab is there. In AML, we are using gemtuzumab. In TALL, we are using nelrabine, for example. In neuroblastoma, we are using anti-GD2, dinutuximab, like that. So there are conditions where immunotherapy has come in a big way, either in such places where the toxicity profile of chemotherapy is worse,
Correct.
so that's why we replaced, or in some conditions like metastatic neuroblastoma where the cure rate was dismal with the conventional treatment. And with immunotherapy, it's making a huge change.
So there's a lot of scope for repurposed immunotherapies in
Yeah.
pediatric cancers, and there's still a lot of research which is
Exactly.
possible with respect to
Yes.
immunotherapy in childhood cancers.
So, talking of the word spontaneous tumor regression, which we don't often hear in adult cancers, but in neuroblastomas, pediatric tumors, there is a chance that the tumor may go off on itself. And we also see that childhood tumors do much better compared to adult malignancies. Is it because of better treatment options or is it because of the biology itself?
Well, it's kind of combination of both actually. You used a very good example of neuroblastoma, for example. So typically the neuroblastoma which comes in the newborn period or in the infancy, early infancy, and if it is non-metastatic and it is a low-grade tumor, then wait and watch. Simple observation is good enough because many times these children, the tumor may go away. But having said that, Mija, that's a huge spectrum. You might get a 6-month-old child who's having a neuroblastoma, which is low risk, which might spontaneously regress. On the other spectrum, you might incidentally pick up a neuroblastoma on a routine ultrasound for something else. And then because it is very close to some organ, you biopsy, it is a high grade tumor. Then you do a PET scan for staging and then you do gene amplification. Then there is NMIC gene amplification. So it's totally, shifts to high risk. And
Correct.
there they require entire gamut of treatment, chemo, surgery, BMT, and immunotherapy, and all that. So there is a huge, divide from low risk to high risk. So spontaneous regression can happen. And the disease biology is also different, like you rightly mentioned. And treatment, well, I won't say that pediatric oncologists generally are conservative when it comes to data. For example, you were telling 80s and 90s, because we need the long-term data of drugs. We will not use the new drugs immediately unless there is a safety data and for ethical concerns and so. So it takes some time to mature, the data. Only then we start using it.
In your clinical experience, have you seen any spontaneous regression of tumors?
Only neuroblastoma.
Only
Yeah,
neuroblastomas.
only the low risk neuroblastoma. That's the only one probably. It's
And is there an age
non-spontaneous.
group for that as well? 0 to 2 years
Majority of the time they are infants. Yeah,
infants. So less than 1 year.
yeah, less than 1 year. Majority of the times.
So when you treat kids, is there going to be a post-traumatic stress disorder for kids who have had such extensive traumatic kind of an experience in childhood at a later point of time during their life? Because these are long time survivors.
Yeah.
So you have 25 years of experience. I'm sure you would have had different phases of kids who have been treated. So do you see that kind of a traumatic experience which could impact their quality of life at a later point of time?
So fortunately for us at HCG, we have a very good long-term follow-up. So
Correct.
patients who I've treated 15 years ago are still on regular follow-up. So I can definitely comment from my first-hand experience on this. Now the thing is, see, children. When you talk about children, it's 0 to 18. So
Mhm.
if we classify them into three groups, let us say 0 to 6, and then 6 to 12, and then 12 to 18. Then we have three subgroups. So let's talk about 0 to 6. 0 to 6 children, majority of the time, their understanding is very limited. So majority of the time we are focusing our counseling to the parents.
Correct.
We focus only small little things because child might want to know whether I can eat this or not, whether I can play, when can I go back to my nursery school and stuff like that. 6 to 12, nowadays it's a changing era. They are quite intelligent. They have some kind of working knowledge, and at times, they might ask you this question, Doctor, do I have cancer? What is the meaning of cancer? Or they might have read it on the net or something like that. 12 to 18 is one of the most difficult, age groups to manage. They are not complete adults, they are young adolescents, and we all have challenges in
Correct.
young adolescents. So counseling them and keeping them at majority of the time, parents may tell you that please don't tell them anything about the diagnosis. That's the first thing we
Correct.
try to tell,
Mm.
that no, 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 child needs to know. You don't have to use that word, cancer, disease free survival, relapse, and etc. But there are a lot of other things they want to know. For example, for a girl at 13, 14, or 16, she just wants to go to high school or college. The biggest thing is hair loss.
Mm.
She just doesn't want
Exactly.
that. She wants to know what can be done for this. For a boy, there might be some other challenge. If he is 16, 17, he might ask you about fertility issues.
Correct.
So you might be focusing on that. So there are so many things. So you have to, counsel, and then we have a good psycho-oncology team at our center whom we involve for all this. So these children definitely have some kind of, PTSD over a period of
They
time.
do have.
They do.
They do have, but the incidence is fortunately far, far lesser. So if you have dealt with these situations during the acute phase well, and you have a long-term follow-up where you try to focus, I think one of the arts of medicine, which we all keep discussing so often, is we as physicians and clinicians need to listen.
Correct.
Yeah.
Majority of the
I think
time
a
we are
lot of
talking. If we listen, then we will know what their thinking is, what they want to know, and stuff like that. Then we can probably tackle these things much more efficiently.
it is teamwork at the beginning, and
Yeah,
also
absolutely.
And follow.
professional help is absolutely important.
So, sir, you beautifully explained the three age groups. So, you also mentioned that it is very important that they get to know the diagnosis. For each of this group, how would you explain the diagnosis of cancer to them?
Well, first we actually talk to the families. Okay, let us say a new child has come to my OPD. Let us say the child is between 0 to 6 for leukemia. First, we talk to the families, explain about the diagnosis, treatment plan, etc. And then I actually tell them that we need to talk to the child also. So obviously, the parents will say, "Doctor, please don't tell these things, to him or her." So I will tell, for example, regarding cancer to the child, see, Sunny, you will not be able to go to school for few days. You might have to stay here, and we are going to put some medicines which will be given in the bottles and all. We try to show them some video, try to make it like a play event, like that, try to make them meet other children who are there, and then tell them that there are a lot of things you can do. For example, you can play, you can draw, you can paint, you can watch, you can mix with other children, as long as they are not having some kind of open infection. So like that, try to create like a home atmosphere, something
Your
like that.
pediatric ward itself is
It's
Yeah,
colorful.
well,
we
yeah,
are
Yeah.
blessed.
differently
We
designed.
are blessed at HCG
Yeah.
because we have a beautiful ward where actually, I have to quote this. There are a lot of children, Dr. Lohit and Dr. Kritika, who actually tell that we want to stay in the hospital.
Yeah, because
Yesterday,
it's like kids.
yesterday I had a child with ALL who had come for simple Vincristine injection, and the mother complained that he's not eating very well. So I told, okay, if he's not eating very well, then I'll not send him home. He needs to stay here. Then he said, absolutely fine. I want to stay here. And that's what the mother is telling. Actually,
Correct.
he wants to stay in the hospital, sir.
There is a
He's not
play
going.
area. It's
Yeah,
very colorful.
yeah.
I mean,
It,
kids
it
are like
makes an impact.
Yeah.
impact.
And sometimes in adolescent age group, when we are counseling, we definitely need to take consent from the parents and probably involve the psycho-oncologists also from the beginning and try to understand their concerns, you know. For example, let us say a child, a girl or a boy, they're in 10th or 12th, they're about to write the board exam, and then they are diagnosed with something like leukemia, which is an urgent diagnosis, requires treatment. So the focus has to change. Sometimes I use a very trivial example, telling that you had an appointment with me today for this, you know, and I saw the list this morning, and okay, this family is
Mhm.
coming today. It's referred by Dr. Lohit, and this child is having, leukemia. So I know I have to attend to it. But let us say today I had a death in my family, God forbid. Let us say my grandma expired. What would I do now? I will not come to the hospital and attend to you. I would
Correct.
attend that one because that is priority now. And I would inform here that one of my colleague will attend, and then tomorrow or day after I will come and attend because that is something like that. So your focus was your 10th board exam, but then you have something much more important which has come up. So we have to
Correct.
prioritize this. And then we won't let it go. And there are a lot
Correct.
of children, you also know, we have
Yeah. Yeah.
managed who have gone ahead, and the next year they have given the board exams
Exactly.
and they have actually been toppers. Some of our patient families, they come back and tell us, recently one of my patient whom I treat, my first leukemia patient, male, 15 years ago, she got married recently.
Wow.
There are a lot of other families who have married and they have children. I have three of my patients who are doing medicine, and they have told me, doctor, you wait, we want to join you. And a girl
Wonderful.
and a boy, they want to join our team. So that's the kind of, motivation they have from us. And that's the kind of, willpower that they have. And that gives us a lot of motivation to continue doing the good work, actually.
I think that means, when kids have cancer, once they finish off the treatment, they still can have a normal life after it. Like, for example, you gave examples of three kids who have joined medicine, so the education can be normal. And what is the time frame of follow-ups, and what are the kind of investigations, or what are the kind of tips, lifestyle tips you give to patients who have undergone cancer treatment and for the future well-being?
Yeah, let's take two examples. Let's take the example of bone tumors, for example. We manage a lot of bone tumors in our center,
Sarcomas.
multidisciplinary team with you, ourselves, and Dr. Pramod, our ortho-onco. So we do a lot of limb salvage surgeries, chemotherapy, and that's most of them will be adolescents. So the
Correct.
first thing is, other than the cure and the limb salvage, we are focusing on fertility.
Right.
So we offer sperm banking and ovum banking for them upfront, so that fertility is not an issue. And then the chemotherapy dosages have to be such that we don't have infertility issues
Mhm.
later as much as possible. Then when they grow up, in that age, you have to focus telling that once the treatment is over, they have to continue to come for follow-up. For example, for bone tumors, we would ask them to do a CT chest and a local MRI. And God forbid, if there is a recurrence PET scan, and continue the rehabilitation program for the limb. A lot of our patients after limb salvage are, runners.
Correct.
They're playing basketball and football and so on and so forth. So they're doing well, but they need to be on regular follow-up. We actually follow them up once in 3 months for a couple of years, and then once in 6 months for next 3 years. And after 5 years, we tell them that it's not mandatory to come for follow-up because they should also feel free. But most of the families who are staying in the same city, they would always want to come back once a year for follow-up. So we focus on two areas. One is disease recurrence, and two, any long-term side effects of treatment. And three, like you mentioned, looking for PTSD, post-traumatic stress disorder, or something else that they are having, other challenges that they are having. Let us say some child has received radiation and then they are having issues related to endocrine, let us say
Correct.
growth or
Right.
some endocrine effects. So those things have to be
So
managed
those things
adequately.
has to be monitored for longer years.
Longer years.
Yeah, so it depends on which cancer. For example, brain tumors, if they have received cranial radiation, if something like craniopharyngioma is there, something like that, then they have to be monitored for long-term side effects related to both radiation and chemo, endocrine, functions, growth, and all that.
All right. So talking of research in pediatric cancers, one is with respect to reporting pediatric tumors itself, so that we have an absolute data of how many pediatric cancers is really happening in India. Let's say there are 100 cancers pediatric that is occurring. How many of them do get reported in the form of a registry?
Now we have few population-based cancer registries in Bangalore and in India, but we do not have a strong national database. But
Right.
now ICMR has done a lot of efforts and they're trying to capture the data. So if you just make it very simple, Now our Bangalore population is how much? Close to 1.5 crores.
Probably six. Karnataka is 6 crores. Yeah,
Karnataka,
probably we are
one
probably
and a half
one and
crore,
a half to 2 crores.
1.5 crore. So our population, 30% of the population is below 15 years. That's as per stats.
Wow.
So if you take it as 1 in 10,000, okay, so you have close to about, if it is 1.5 crores, so we have 50 lakh children
Right.
below 15 years.
Okay.
So if you take it as 1 in 10,000, then that's a huge number.
Right.
And then Bangalore being the hub, not only for so many other things, but also for medical care. You would also get patients from the neighboring towns, villages, neighboring states sometimes, you know.
And
So
even
that's why that's
countries
a,
as well.
yeah,
Yeah.
the other
Yeah.
countries as well. So that's a huge, huge number. So yeah, number is huge. Yeah.
So a miss out of reporting can happen because of lacking registries.
Well, lot of miss out used to happen actually. When I started my career about 20, 25 years ago, the database was very, very poor. But nowadays, you know, there are a lot of clinicians within pediatric oncology who are interested too much in epidemiology, for example.
Right.
So they strongly recommend for data reporting and maintaining a strong database. We are blessed because we are at HCG, so we have a strong database, and our colleague Dr. Amrit and his team, they do a fantastic job. So we have a strong database. Like that, most of the institutions are having data, and at government level also, a lot of work is
Correct.
happening at the ICMR so that we have a data, because data is,
Crucial
yeah, crucial
to understand.
for
And
everything.
what about these phase 3 and phase 4 trials or established proven efficacy trials that happens abroad? Is India part of them at all, or in how many proportion of these multi-centric trials is India a part of? And how many investigator-initiated trials comes from India?
Well, compared to adult oncology, we are far, far behind
Okay.
actually. You know, as HCG is a big hub for a lot of clinical trials, and you all are part of so many adult clinical trials, but our pediatric numbers are far, far smaller.
Small.
Right.
For various reasons, you know, pediatric clinical trials coming to India phase 3, 4 is less, but it's improving.
Right.
Things are changing now.
Mhm.
Right.
So right now we have about 3 clinical trials at HCG, and right now we've been approached by a lot of you know, international. Like recently, couple of weeks back, Forum trial.
Mhm.
Forum trial is you know, that is a trial to see if we can omit radiation from conditioning,
Conditioning.
TBI
Right.
based in
Okay.
Total
ALL.
body radiation.
So
Okay.
that trial is focusing on whether we can omit radiation from. So that trial now they're expanding globally, and they have asked, you know, just interest to show how many centers are. So I have actually written to them and said that we are interested in being part of this. So multicentric trials are also coming, and trials is it is the present and it's going to be the future.
Future.
Yeah.
Yeah. So I think, coming to, a lot of, mothers do get genetic screening done. So is there some kind of a blood test where, see what happens with childhood cancers is they come to doctor when there are symptoms. Is there a kind of screening tool or probably a blood test where you can detect the ctDNA and probably like, foresee a kind of early detection of childhood cancer? Is there a possibility?
Well, not to the general population. If you see WHO guidelines, or if you see ICMR or our own institution guidelines, we don't go for camps for screening of normal children to detect how many children are having cancer, because childhood cancer, as I mentioned, it's about 1.6 to 4.8% of total cancer. So it's less
Mhm.
than 5%. So if you go to the general population and do some kind of screening, let us say for leukemia, blood test or marrow, or for brain tumors doing MRI, or for abdominal tumors, let us say ultrasound. So that's not the approach which is recommended, because our pickup rates are much smaller, incidence is much lesser. But to the focus group, let us say you have an identical twin. One twin has developed a malignancy, then definitely the other twin has to be screened for that, whether it is leukemia or retinoblastoma. Let us say we have a tumor like osteosarcoma or retinoblastoma, where we know the gene.
Mhm.
So we definitely just test that gene in the index patient, and then the rest of the siblings need to be screened for that. If you have a child with Down syndrome, like for example, you know, Down syndrome children will develop leukemia, especially AML and ALL. So those children need to be on follow. For example, children with neurofibromatosis and other, you know, cancer predisposition syndrome. So focus groups
In
in
specific
specific
list.
subgroups, or in a family where one child is affected with cancer, then in those groups, you know,
And it cannot be generalized.
yeah,
Generalized.
it cannot be generalized.
Talking of the financial perspective, when we speak of adult cancers, at least a good proportion of them now have an insurance backup. How many of pediatric cancers or pediatric patients have that kind of financial support? Are there institutions that are trying to help pediatric populations with respect to this finance?
Yeah. Well, if you see the majority of the families now have some kind of insurance, but many of them don't have also. So I don't say majority. There are few percentage of families who have insurance, and majority of them actually don't have. But if they are part of one of the government schemes, let us say if they're employed in central government or ESI, some kind of coverage they get from there. But insurance in India, majority of the times, the family floater policy they take is for 3 lakhs or 5 lakh rupees. And sometimes the cost of treatment might be higher than
Correct.
this.
Right.
But then when you are treating a child with cancer, the cure rates are excellent.
Excellent.
So there are a
Right.
lot of people who would come forward to support. Like, for example, in our institution at HCG, we are blessed because we have a huge backing from the management institution. We have HCG Foundation and we have other, NGOs who are trying to support both
Crowdfunding as
at
well.
the crowdfunding is there. So, and we have time. If we can get started with the initial treatment, then rest of the treatment, we can do some kind of, crowdfunding. And there are a lot of charitable associations who are coming to help the cause actually.
Is there a specific scheme or something that you would want the public to know where they can access or register to get the support?
Well, they have to get registered to the institution first, I think. They have to choose, let us say, if they have come to us and they want to get the treatment, I think we all would agree that,
Exactly.
our mentor, Dr. Ajay Kumar, and our management at HCG, we say that please do not deny treatment to anybody. And that holds good to a large extent, and especially for childhood cancer, where the cure
Correct.
rates are excellent. So anybody who comes to the institution, if they are not financially affordable, we can do a lot of things to make sure the child gets the right treatment. Because in our opinion at our institution, we feel that child is not only the future of that particular family, but also for the society and for the
Correct.
country as such. So, stakes are much higher when you are treating children with cancer. So we should go all out and do our best to make the best for them.
Today you did mention about the thalassemia support group.
Yeah,
Yeah, and the financial aid which comes
yeah.
to those patients.
Yeah. Thank you for reminding Dr. Kritika. Actually, I should have mentioned that. Now, you see, we have something called as Thalassemia Bal Seva Yojana. Now, we have a huge number of thalassemia patients in our country, and thalassemia is a simple blood disorder where children are born because of genetic defect. They start requiring blood transfusion at a young age, 5, 6 months of age, and they are dependent on transfusion all their life. And if we don't, do bone marrow transplant for them, majority of them would die in the second or third decade because iron overload related complications. So now Government of India, along with Ministry of Health and Ministry of Coal, they have come up with a program. Coal India CSR is supporting this. We have something called as Thalassemia Bal Seva Yojana. So right now, all over the country, we have only 17 hospitals which are recognized for this cause, and HCG is one of them. We have 4 hospitals in Bangalore. HCG is one of them. Why they've chosen us? Because we have done good work in bone marrow transplant. We have done good work in thalassemia. So now, if the patients who come to our center, all they have to be is they are Indians, they have Aadhaar card, and their income has to be a little bit below that, the you can say the higher income tax bracket, which most of them would be. And then if you apply with the necessary documents at the government level, they are giving us funds up to the level of 10 lakhs from Coal India. That will be transferred to the hospital. So that's a huge, huge help.
That's a huge
That's a huge
difference.
help. Right now, just on May 8th, we had this World Thalassemia Day in New Delhi. I had gone for that meeting, and all the centers who are part of this Thalassemia Bal Seva Yojana were honored. And I was representing my center. So they have told us that go out and big way. They have delegated something like 100 crores funds from, and out of that, they want to focus a good amount, maybe 10, 20, 50 crores for,
Great
Thalassemia Bal
government
Seva.
initiative.
Yeah. So now they have been able to do in the last 5 years about 700 patients
Wow.
through the Thalassemia Bal Seva Yojana program. But they are encouraging us to go all out, and we want to make our country as thalassemia free
Right.
in few years from now. Cure the
Wonderful.
patients who are born with thalassemia by bone marrow transplant, and prevent the children being born with thalassemia by
Screening.
genetic screening, antenatal counseling, and so on.
It's wonderful.
It's interesting.
Sir, you've been in practice for so many years. You've treated a lot of childhood cancers. What is that unforgettable moment or an emotional moment where a child has expressed to you during the treatment or post treatment?
Yeah, one of the things very common is many children ask us this: why me? And it's a big pause after that, and probably even at this level majority of the times it's a pause at my level also. I have to just silence myself for a while and then think of what answer I'm going to give, because it's so difficult to answer that question. Child would say that, I just started going to school and then this happened. I just joined basketball and then this happened. I'm going to write my board exams and then this happened. So it's so difficult sometimes. And the other thing is sometimes, rarely, we come across situations where childhood cancer is in advanced stage and we are not able to cure them. And then they would ask you, Doc, am I going to die? And it's a big, you know, and you cannot lie at that point of time. So what do you want to tell at that time? That's a big challenge. But on the other extremes, there are also good things coming up. Majority of the children do well, and then they come back to you, and then they thank you, and then the families. So it's a very, this is a very niche specialty. Really requires a lot of motivation and
Motivation and
sincerity to be in
counseling as
this
well.
field.
And emotional intelligence as
Emotional
well.
intuition. Like you would agree, no, Dr. Kritika, if as a parent, if my
Right.
child is just having cold cough fever,
Yeah,
middle of the night, child is crying, we
Yeah.
all, panic and get scared, and
Yeah.
we want to call the pediatrician in the middle of the night. Having a child diagnosed with cancer or
yeah,
blood disorder
emotional.
like aplastic
Yeah.
anemia or
Yeah.
thalassemia, emotions are very, very high
From the parent
from the
perspective,
parent
from the
perspective.
child perspective.
Yeah, yeah. And in our country, we are blessed that we have an extended family support. Majority of the time, parents and grandparents are also involved. And many times, uncles and aunts. So sometimes our counseling sessions, we
Correct.
have 10 people, and we have to go for hours together. So we need to spend a lot of time in counseling, and we need to spend a lot of time in deciding what kind of treatment has to be given. Individualized treatment, precision medicine, that's what we should do.
What is that emotional moment where probably you would have treated a patient? Usually, what happens is when we treat cancer patients, once you go out of the hospital, you try to turn off.
Mm.
So, probably one moment or two moments where you're not able to turn off and where you've taken it home and it's affected you. Is there a moment? Because it does happen with children, right? So,
Yeah,
these are tiny dots. So, there's a lot of emotional quotient when you treat
yeah.
childhood cancers.
Fortunately, such situations are not that common. So it's good because if that had to happen on a everyday basis or even on a weekly basis, then probably our lifespan would have gone down by another 10 years, I think. As such, as doctors, our lifespan gets down. So fortunately, these things happen less often. But like I mentioned, let us say you have a child with diffuse brainstem glioma where,
Correct.
we are not able to do surgery, and then we do radiation, and then we do a combination of some chemotherapy, immunotherapy, and majority of the time we are not able to give long-term cure. Only occasional cases we are able to. So such events, when they happen, it's a big setback for us, and that time it lingers on in our mind for a very long time, and we definitely take this home, and we'll have sleepless nights, and we'll keep remembering that child and the family and something.
Yeah.
But fortunately, it's less common.
Okay. So on one end, we know that majority of pediatric cancers, we don't know the cause. Let's say a child who has been cured of a pediatric cancer but is addicted to junk food eating. Today it's a major concern.
Yeah, yeah.
Many parents are worried about their children being addicted to junk. That can either predispose to future adult cancers or
Definitely,
even pediatric cancers.
definitely,
How do you
definitely.
see that?
Well, that's very important, especially the young, children who are between 10 to 18, I could say. As soon as the diagnosis of cancer is made, at that point of time, we are not too stringent about the dietary. Many
Correct.
times, parents ask, Doctor, ಏನೇನ್ ಊಟ ಕೊಡ್ಬೋದು? What all we can give to the child. So one of my pediatric teachers, when he taught me the art of pediatrics, he used to say, Doctor ತಲೆ ತಿನ್ನೋದು ಬಿಟ್ಟು ಬೇರೆ ಎಲ್ಲ ತಿನ್ಲಿ ನಮ್ಮ ಮಗು ಅಂತ.
Mhm.
So meaning to say that let the child eat whatever he or she wants other than, eating my head, something like that. Because at that time, there are so many complications. So we can allow them to eat whatever they wish as long as it is hygienic and clean and all that. But once the treatment is finished, we have to focus on lifestyle.
Mhm.
We have to tell them the harmful effects of junk food and lifestyle related, obesity, for example. We are the
Correct.
diabetes capital. We are the obesity capital. And all these are lifestyle related. So eventually, over a period of time, those children who have one of these ill habits or have obesity or have lifestyle related, issues, they would not only develop, God forbid, diabetes, hypertension, ischemic heart disease, but also cancer. So they can have recurrence of this cancer, or they
Yes.
can develop second cancer or the adult type of cancer because of this. So we have to focus. Majority of the time, these children are very motivated, and once
Correct.
they have fought this and come out,
Right.
they want to make sure that they will not suffer from,
Right.
because they know this happened not related to lifestyle.
Correct.
My parents are not responsible for this. I was not responsible for this. But
Perfect.
now my life is in my hand. I'll make sure that such things which are preventable,
And they
especially at the last,
understand.
They
they
understand.
understand. They are strongly
Wonderful.
motivated. Majority of our patients and children, who have got treatment, they want to come forward. Whether it is at the newspaper level or the channel level or the YouTube, and They want to communicate to others that, okay, this problem happened to me. I fought this. I have come out.
Amazing.
And yeah, that's how it is. They want to motivate and help others. And a lot of families also come forward.
Correct.
They want to get connected and they want to help each other.
One last question. How do you manage the parents undergoing this kind of trauma?
Well, it's an art. Actually, medicine is an art. And here also, I mean, like I mentioned, when they are diagnosed first time, I think in the beginning, I use this statement very often. I said, whatever has happened, it's not related to something that you have done. And there is nothing you could have done to prevent this. So let's not break our head on this. For example, I give the example of polio, for example. Let us say if you don't give polio drops to your child, there is a chance that your child can develop polio. So we would say that why didn't you get the vaccination done for?
Yeah.
So you don't have anything like that blanket, some kind of prevention where we can prevent cancer. So this is something which had to happen. It happened. It's nothing like karma or something,
Correct.
So please come out of this. And the immediate second statement has to be at that time, except for those rare ones where cure is not possible. Very rare ones. Majority of the time, we have to give them the positive motivation that this is curable.
Super.
Your child is going to be fine. It's a journey. We'll have to take it together. Okay, there
Amazing.
might be, problems, but we'll deal with it. We'll
We are
come out
part
of
of
it.
the
Yeah, we
family.
are
We'll
part of
fight
it.
it out together.
And sometimes I say, let us say it's a bad dream which has come and it will go away too fast. Okay. And the best thing is children who are below 6 years will not even remember what happened at that age. So the children whom I have treated at that age, now when they're adolescents or adults, when they are brought to follow up now, just like that, for a birthday cake cutting, or they are getting, graduating, they are getting into medicine or getting married, wedding card, invite. They say, why are we coming to this doctor? So I just hold the hand of the father, mother, and say, just stop. You're not well when you were a kid, and I treated, and your parents here, every time they just keep coming and they want to thank me because the child was below 6, he or she doesn't know. So that's the best thing, blessing in disguise for us, actually.
Superb, sir. So thanks for your valuable insights. It's been a pleasure having you.
Thank you.
Okay. Thank you
Thank
so
you.
much.
Thank you
Thank
so
you.
much.
Thank you.